So it is week 7 already. It's going by quick. Your next exam is week 9. So next week you're going to be doing reviews. I did have a posting that's going to come out at midnight tonight, which will have in your PowerPoint. It'll have all your weekly stuff in there, all the Kahoots in there, when the reviews are. The first review is Sunday by Professor Luminoso at 3 p.m. Then it's Tuesday, Professor Stiles, and then Thursday at 5 is going to be mine. So you'll have 3 of them, and you'll have them really before the weekend. So you're getting them all pretty quick, that you'll have all the information for you. As I said, I did go through and I did make that exam already. So I think it's a real fair one. And I know that the information is covered in the PowerPoints and the Kahoots and your weekly papers. So I know the information's there for you. So
The Kahoots are really helpful too. I really like those. I really like that. And
I like
there's no quiz next week.
next week we have quiz 5.
Okay, all right.
And you do have a sheet on week the week there. So that will be on that information.
Okay.
So um after week 9, you're going to say, so we still have week 10, right? We're going to start HESI reviews. I've got one that can last all class. It's literally your NCLEX book on pediatrics. I've taken out all the key stuff, all the key hints. I'm going to go over it all. It's 90 some odd slides, but it's everything. And, if you hear it, sometimes that hearing it will kick it and remember it for those HESIs, okay? And then, of course, I do have HESI Cahoots also. So we'll be working on those too, and I'll be sending everything I have to you, in order to help you.
Thank you.
So anybody have any questions, comments, concerns?
No.
Okie dokie. Keisha, are you coming to class? Miss Anderson? There she is. She's coming. Thank you so much, my dear. Appreciate it. Okay, let's go ahead and start the PowerPoint. Now, one of the things I want you all to realize is that underneath the PowerPoint is note pages. And Professor Stiles has really put key information in those note pages. So don't just look at the PowerPoint. All you do is come to the bottom and you could just pick it up and you can look at it and you can put it down when you don't want to see it. Okay. Just so that you know. I don't know if you know that. So I wanted to make sure you do. So we're going to first go over, there's a lot of chapters today, a lot of information. We're going to be going over the child, let me see, 6, 7. We're going to be going over the conditions, blood forming, and then we're going to go over GI. So it's a little bit of both worlds. And then next week we have quite a few different chapters, but I've broke it down into a great Kahoots and a great PowerPoint for you, so you'll be okay there. So when we talk about blood and blood products, you talk also about what's in the blood. There is an immune system, white cells, right? White cells are a part of it. And that's part of your lymphatic system. And it really will try to help your body deal with organisms. We know that they drain, they destroy them, the antibodies are produced there, and there's many conditions like lymphadenopathy, which means swelling of lymph glands. Children do not have swollen lymph nodes unless they're sick. So if they're swollen, they're sick because a normal, healthy child should not have them. We consider the spleen part of that lymphatic system. So sometimes we can have problems with the spleen where it gets enlarged. Again, what is the spleen doing? It's really trying to fight infections, and there could be also other problems with anemias, and we'll go into that. Sickle cell is one of them, and then liver malfunction. When the liver don't work, then the spleen tries to catch up. So in the blood, there's a lot of components. So just looking at a CBC, we know there's white cells, there's red blood cells, and then there are other bleeding things like the platelets. And then other components really talk about the types of cells that are in there. But we have the liquid that carries this stuff called plasma. Then we have erythrocytes, and erythrocytes are where iron and oxygen is carried and carbon dioxide is sent to the lungs to be filtered and to replace oxygen to send to the body. So erythrocytes, these are red blood cells, okay, are very important. So low hemoglobin hematocrits, you're not getting oxygen. You can see things that can happen. Uh, not being able to have energy, right? One of the things called anemia. We also have leukocytes, and these are the white blood cells, and these are what helps the body fight infection. And what you'll see is elevated white blood cells when it's a bacterial. Viral, your white cells don't increase at all. Sometimes they'll do a CBC to rule out, well, do I need to treat it with an antibiotic or not? If you have a normal white blood cell count, we'll say it's a viral condition. And that's why sometimes we do that. And we know the lymphocytes are produced in the lymph node areas. Now, I sort of started to mention what happens with erythrocytes, hemoglobin, hematocrit, when they're low. And it can be caused by many different reasons. Again, what do erythrocytes do? Red blood cells. It carries oxygen. It carries food, the iron to the body, and it gets rid of the waste, the carbon dioxide. So it's really important. If you don't get food, you don't get oxygen, you are going to be, of course, pale. That's number one. Sometimes it's just looking at the tongue and inside the gums. Sometimes I can see it on some pale white children, the ears get like almost iridescent white. Okay, so it's sometimes hard to detect, but the symptoms usually will lead us there. So they'll be pale. They have no oxygen. You have no oxygen, there's no fuel to be able to move, to, be active. So you're weak. And then, of course, the heart. The heart says, I don't have enough oxygen in here. So, because I don't have enough red blood cells, but let me beat a little faster. Maybe I can get that oxygen around quicker. So you become tachycardic and tachypnic. Your breathing, goes the same with the heart. You get short of breath, and then the heart just gets tired. It's beating so much because it's trying so hard, and you could go into congestive failure or just cardiac failure. Now, iron deficiency, most common. And usually it's the young children, like your toddlers. They're very picky eaters. And now they're placed on whole milk, which doesn't have iron, because up to that point, they're having iron fortified formula or breast milk. So they're getting enough iron that they need. But when they switch, and then they're picky eaters, not eating those green leafy vegetables and meats and grains that they should, that's when you're going to see these children come into an iron deficiency anemia. Again, you're pale, you're irritable. Why? No oxygen. You don't know what to do. You get anorexic because you don't have any energy. And then, of course, you're not able to do normal activities. Sometimes just, going from the car inside the house, you're short of breath. And sometimes you might see a decrease in activity because children tend to gain more weight when they drink a lot of milk, the whole milk, okay? So, but we're not going to switch that because they need that fat in there. We might decrease the amount, but not take it out of the diet. So, how do we diagnose? Well, we want to see it just a simple CBC. We might draw an iron level of the blood if we're suspecting it's nutritional. And of course, we're going to see a hemoglobin hematocrit will be low. Now, we don't always assume that a low hemoglobin hematocrit is due to nutrition because it can be due to GI bleeding, right? So we need to rule out, is it in the GI system? And doing a stool for occult blood covers that whole GI system. Now, iron is given, or we increase the diet, depending, or both. Now, liquid iron is something that we give children. It's brown, it can stain the teeth, so sip it through a straw. The other thing with iron, never ever give it with milk. And why? The stomach acid breaks down the iron and makes it usable for the body. You drink milk, it covers the stomach acid, it never gets broken down, and then you're not getting the iron. Take it with orange juice. It is the best thing because the acid of the orange juice, the acid of the stomach will help aid in the breaking down and the absorption. Now, parents should know iron deficient anemia. What do we do? Well, number one, first 6 months, it's either breast milk or iron fortified formula. The other thing is, again, no milk with iron. And the other thing is, have you ever seen a stool on any person that's taken iron? It's really like really sticky, could be almost dark, almost black in color, call. But tarry green could be another expression of it. It just doesn't look normal. Can you imagine giving a child some iron, not telling the parent, and all of a sudden they think they're bleeding in their stools because it looks dark? It's just not normal. Like, what's wrong with my child? And again, with iron, they say don't give it with meals. It should be before or 2 hours after because we want that stomach acid again. Now, there's sickle cell anemia. Sickle cell anemia is those shapes of those cells are in sickles. And it comes when you have two parents that have a gene. And when they have the gene or the trait, they have the possibility of either putting the trait on the child or the disease. Okay. So both of them have it. Most likely, this child can get sickle cell. One could be a trait or it could be a sickle cell. It all depends. You don't have to know which one does what, just that you need a parent to have the trait or the disease to pass it on. So, sickle cell anemia, what do you see? Well, initially you're born with blood. Usually it's of normal shape. And then those cells die off and your body starts making your own cells in the mid of the first year of life. So, we usually don't see it till about the first year. We're noticing the child's getting pale, getting something's going on, and then we're going to see the symptoms. Well, what is sickle cell anemia? Well, in the body, there's blood vessels and there's bifurcations. And these little sickle cells get caught. And then one builds on top of each other and it swells above it. And below it, it tends to have no blood flow and even some cell death can occur there. This happens more in dehydration or if it's cold outside, or the extremities cold, because those cause constriction of vessels, right? So these are very thin veins, it gets stuck and it doesn't move. And what you'll see is the swelling. Usually the hands and the feet are the ones we see on children first. Now, sickle cells die quickly. Therefore, their hemoglobin hematocrits are always low. I have never seen a child come in the ER with a sickle crisis with a hemoglobin above 7. They usually come in 7 and lower, and you expect that. So we're giving blood in the ER because we're trying to at least give their cells back. Oxygen is in those cells, right, that we're giving. So one of the things that we do quickly, so they'll always have very, very low hemoglobin hematocrit. These children can have pain anywhere there's a cell. There's a headache, we're going to worry about a stroke too. We're doing neuroscience. It could be in the eye vision problems. So we're definitely checking that out. It could be in the chest. It could be in the abdomen. Could be a splenic crisis. It could be so many everywhere things. So very important that where is it and what do we need to do for these children? Some of the things you might see also is, these children, they're immunosuppressed. One of the things that we have to worry about is infection, right? These children with minimal little infections tend to go into crisis. And a lot of it's the infection in the body, but fever burns fluids too, right? So again, those vessels are smaller. Those cells get stuck, causing a sickle cell crisis, okay? It can cause convulsions. I mean, remember, anything in the head, and you're always at risk for a stroke if it's something in the head. Now, vaso-occlusive is when the vessel, usually you'll see them in the hands. I've seen them in the knees, in the ankles, where all of a sudden it swells and it's painful. I mean, it's very distinctive. The hands get very swollen, almost like they have edema in it because you can't drain anything backwards. It's usually up here, up higher is where that sickle cell is. So below, they just tend to swell up and it hurts. These children, they're crying. They require morphine. And many times it gets to the point of Dilaudid for these children. It is hurting, and they even have pain medicine at home. And usually it's a simple little Tylenol with codeine. They tell them to take it quickly when they first get the pain, but they don't always, or they don't always have the medication available at home. A Spunk's equation is when the spleen gets clogged up and it can get really big and it can burst. So that's a big deal if it's in the abdomen. Aplastic is when the cells are not working. And then a hyperhemolytic is when they're bursting, bursting, bursting. So your hemoglobin hematocrits are really low. So think about this one. During a routine clinic visit, the nurse notes that an 18-month-old child has pallid skin, is lethargic, and is overweight. The mother says the child's become less active, increasingly irritable. What condition should the nurse suspect? Well, what of those two things I just talked about this could be? Is it iron deficient anemia or is that a sickle cell? What would you think?
Sickle cell. Iron deficiency.
They're not telling you they're in pain, right? Sickle cell crisis is a
Oh,
pain. Iron deficiency, they're getting lethargic, less active, irritable. They're not getting oxygen, okay? So, iron deficient anemia, again, that's your toddler. I told you they're really one of that groups of children that really are apt to get iron deficient anemia. Okay, thalassemia is similar because it's cells that don't work right. And these cells, I call them my rectangular cells. You have sickle cells, and I call thalassemia the rectangle cells. The problem with these cells is they burst quickly. So you've got cells produced, your body's producing, but they are dying quickly. What's inside that red blood cell? Iron and oxygen. So you have iron spewed into the body, which can become toxic. And then iron, the O2, they're not getting oxygen. So again, these are children that are tired. Problem with thalassemia, these are the group of children that get these are usually Mediterranean descent. And sickle cell is your African American that get them. Thalassemia is Mediterranean. So sometimes knowing culture of your patients can help you diagnose it. So thalassemia is producing a lot of cells, but they're dying, 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 dying. When we talk about different sorts of thalassemia, and usually what you're tested on is the major, which is Cooley's anemia. It's another word for it. This is the one where these children must get blood transfusions to live. Their body doesn't make cells. They're burst immediately. And many of these children have to have splenectomies. Can you imagine getting blood transfusion weekly? Could be every other week, depending, could be even more often. So it is a disease that they can live with it, but it's going to require blood. Now, hemophilia is when you bleed, right? We get a cut, and after a little pressure, it stops bleeding. Well, with hemophilia, part of what makes your blood clot is not there. We call it a factor 8 or a factor 9. This is hemophilia. There's another one also called von Willebrand, and it's a factor like an 8 or a 9. And if they don't have it, the blood does not clot. So what we do is they can do at-home care, and I've seen parents give factor 8 and do an amazing job. Came into the ER and the kid had fallen down and bruised his knee and it was swollen and they couldn't get a hold of their hematologist. So they came in to ask, should we give it or not? And the ER physician said yes. And the father said, can I give it? And I said, you do it at home. Can I watch? And I did. And this father and this son worked together. The son picked the vein, the father got it in, and it was beautifully done. And again, that stops gives them the factor and stop that bleeding into the joints because that can create problems in the future. Your joints get all full of this material that's, caustic and can cause joint breakdown. These children, if they're not treated quickly, can bleed, and then they won't walk and they'll end up in wheelchairs, which we don't want to do. So one of the things that we see with these children is we're going to do something called a PTT. And a PTT is a bleeding coagulopathy lab test. It measures how thin or thick the blood is. When you have a hemophiliac child, it's very long. So if the normal was 40, in some labs it might be 440, and it could be that prolonged. Now, it can be diagnosed at birth, okay? But it's because we start seeing bleeding. Something's going on there. Sometimes it's usually when we've done a procedure that, like a circumcision, cutting the cord and the umbilical stump keeps bleeding. That's when we're going to have suspicions if we have no other pre-warning to it, okay? I mean, blood usually clots in 3 to 6 minutes. In hemophilia, it could take up to an hour. And if you're a small infant, that could be a lot of blood. So with hemophilia, what do you see? Well, you're going to see blood bleeding longer times. So there'll be some type of anemia just because of lack of blood volume, not deficient from iron, nutritional, just because of the volume it's being admitted from these sores and cuts that they get. Sometimes you'll see blood in the urine. And sometimes if it's bleeding inside and we don't see it, like, can you imagine having a stroke or getting hit on the head and can't see inside, bleeding inside? It can cause death because we're bleeding. Now, if it's in the head, of course, it's occupying space. We're going to see that headache. And that swelling causes vomiting. And that, of course, it also can make you disoriented. But it's the headache that starts, then the vomiting, and then the disorientation. Now, platelets are also a component of the blood that helps with bleeding to stop it. Many times with many different diseases, the platelets are all burnt up, maybe with chemo, like in leukemia or other stuff. So it's one of those things we should keep just a little eye on because if it's below 100,000 and some of them get it 10, 15,000, you're going to have bleeding somewhere and they need to be on bleeding precautions. Well, one of these disorders that can happen that's not due to anything else is called idiopathic thrombocytopenia purpura. Okay? Thrombocytopenia is also what we call low platelet counts. Okay? Now, what do we see? How do we see it? And when do we know we have it? Well, many times they have a upper respiratory infection or some viral something. A couple weeks later, all of a sudden they're getting a nosebleed, spontaneously. And not just one, it could be two or three, which makes us go, we need to do a CBC. And bleeding coagulopathies, maybe this is ITP or hemophilia. You're going to see petechial rashes. You're going to see ecchymosis. You're going to see swelling and hematomas. You might see it in the urine and the stool, but usually it's nosebleed and that rash is what we see that brings these children in. So again, it's something to do with the viral infection, some autoimmune something that caused it, but we can turn this around. And it is in your younger children that we usually see it. And they're like, my kid doesn't go outside. The kid's been, I'm really careful, whatever. Why does they have bruises all over them? And that's when we start thinking of this. So there's petechiae and purpura and bruising, right? As I said, that recent something that's happened to them, and then platelet counts below 20,000. You can see how you really see it, just a simple old CBC. Now, they'll be admitted to the hospital and they'll do a bone marrow aspiration because we just want to see what those cells look like. We want to see what's being produced. So again, this is thin bleeding, right? Bleeding possibilities. So again, checking for their brain, headaches, something going on. We need to be very serious about it. And what we do is we give steroids like prednisone, IVIG, IV gamma globulin, and then anti-D antibodies are some of those things that we do. Now, most of these are acute, and within a year are usually they turn around and they produce their own platelets. It can become chronic. After a year, they call it chronic. And then they might take out the spleen because it's not producing, doing what it should be doing. Now, I've talked about this is a bleeding problem, right? So these are the drugs that we should eliminate. I mean, aspirin, of course. Aspirin causes, it's like giving Coumadin, it thins the blood out, right? Also, ITP, we know there's a lot of bruising, so we need to limit activity. I mean, safety in younger children, making sure they're not bumping and bruising themselves, of course. But we don't give platelets with this. There's other things like leukemia, we'd give platelets. In this case, no, we let the body build up its own platelet count. As I said, bleeding, check the GI tract, check the joints, check the head. And one of the things that's recommended for any disease, actually, upper respiratories or bleeding coagulopathies that are caused by viruses, making sure children do get immunized in those viral things, the influenza, right? COVID vaccines, any RSV vaccines, all of these things we would recommend as nurses because you prevent the viral thing that causes the immune response, which causes the platelets to go low. You wipe that out, they're not going to get ITP. So the parents of a 9-year-old boy are confused about their son's diagnosis and treatment for hemophilia A. They don't want to excessively limit their child's activities, but they're concerned about how to prevent bleeding, how to treat it, and what information and counseling should the nurse provide. Well, what activities can a kid do that can bruise easily and bleed easily? What's something that's good?
Sports.
Which one? Soccer, football? How about
Soccer.
how about swimming? Isn't swimming something where they're not going to be hit and cause bruising and bleeding? That would be a good. How
Yeah.
about bowling? I think even tennis is an easier thing than soccer and football.
Yeah.
So you really they can do things, but different choices that have to be made. And preventing bleeding is, telling these children they can't be riding bikes without protective equipment on. They fall, there should be knee pads, elbow pads, helmets on, and they can't be reckless with it. So the child needs to be helped and treated, and so does the parents need to understand that. So, leukemia. I've talked a little bit about it already, but what is leukemia? Well, leukemia is when the white blood cells are produced and they're immature. And so, literally, you have no white blood cell count. Many children coming in with this usually have a white count of less than 1. And it should be 7, 10. That's a good number on most labs. So these children come in, they're immunosuppressed, they have a fever, they're bruising, they're in pain, they're weak, they're pale, and that's usually when they go get treatment. There's 2 types of leukemia. The one that's the easier one to cure is the acute lymphoid leukemia, ALL. Now, the acute non-lymphoid or myelogenous leukemia, AML, is harder to cure. Okay, they both can be, but there are some differences in treatments. So, with leukemia, your white cells are low, your platelets will also be produced, and because it also affects your bone marrow, it also causes your hemoglobin and hematocrit to be low. So can you imagine these children are so weak? They're just so immunosuppressed by the time that we figure out what to do for them. As I said, they have low grade fevers, usually 101 or less, just enough to be considered a fever. And in nursing, we consider 100.5 axillary is a fever. Pallor, they're pale, they're bruising, and leg or joint pain. My next door neighbor was diagnosed with ALL. And that's exactly the symptoms she went to the ER with. She had knee pain and she was bruising, she was pale, she was tired, she had no energy and felt terrible. And they took her into the ER and they drew a CBC and they found it. I mean, they'll be listless because they don't have blood, so no oxygen, as I said. Their tummies can hurt, lymph nodes can be large. The body's trying to compensate for this immunosuppressive, no white blood cell things. And then, of course, anemia. It's just the body, the way that it, not producing the cells the way it should. We might see it happen gradual or all of a sudden we find it out. And if we let it keep going, the liver and the spleen, because they're trying to work too hard, become enlarged. And then, of course, with liver involvement, you get that lemon sort of color, yellow color. And because platelets are going down, petechiae and purpura, and again, it's the anorexia. I don't feel good. I'm tired. I don't want to eat. I'm vomiting. I'm nauseous, losing weight. And then because no oxygen, you're dyspneic, you're tachycardic, and you're tachypnic, all of those. So how do we diagnose? Well, my next door neighbor who went into the ER, she had all the symptoms, and that's the things that we look for, okay? And then we're going to be doing that CBC, and we're going to do a blood smear looking at the type of cells in there. And then, of course, we're going to be doing a bone marrow. We want to really look at those cells, okay? And usually, when we go into the central nervous system with a spinal tap, we're seeing are the cells in there also. Monitoring kidneys, we have to because, with all of the damage to the rest of the system, we want to make sure the kidneys are working to give medications. They are with fever, they need antibiotics. Some of them we monitor kidney function. So, really important that we look at that. And then what are we going to do? We're going to give chemotherapy, right? Now, with leukemia, usually it's chemotherapy. Sometimes, depending on swollen spleen or whatnot, they might do radiation, but usually it's just the chemo. And the first part is called the induction period. And they give these children a couple different chemotherapy agents. And it's intense for the first 4 to 6 weeks. And they literally get into remission after those 4 to 6 weeks. It kills everything, including good cells, white cells, red cells, platelets. So you can see the body's, blood source is being diminished here, right? Then they do a little more. They go into the central nervous system, they go on maintenance, and then they go into this, just making sure, finding out if there's any little cells hidden anywhere. And that's why they do the rest of it. So if all of these things don't work, what they'll do is a bone marrow transplant. My nephew had 2 bone marrow transplants with an AML. So I've watched this occur, and today he's fine, absolutely fine. Now, chemotherapy is hard. It causes nausea, vomiting, hair loss, anorexia, anemia, bone marrow depression, and it can cause things like peripheral neuropathy, which means pains shooting down nerves, down arms, down legs, and it really is uncomfortable. Another thing is because they're not eating, they're not getting good nutrition because they feel horrible. Many of them become severely constipated. Remember, we don't want them to push down hard, right? Number one, because of the nerves that are there, it can cause that peripheral neuropathy, but it also, with all of the low platelets, blood cells, again, you're pushing could open up a vessel in the brain and cause a brain bleed and a stroke, right? Another thing we give is steroids. Now, steroids are great. It stops the inflammation. Actually, there's a euphoric feeling on steroids that are given, but remember, there's side effects. And depending on how long they're on it, they get the big round face, they gain weight. And the one thing we as nurses need to monitor is infections because it just masks all the signs. So the kids, they're
Can y'all
confused.
tell my eyes are closed when I lay down?
The kids are confused. They don't know what's going on. And one of the things is, being able to talk about what's happening and what you're doing. And, children are your biggest eyes. They'll tell you when they don't feel good, when their head hurts, when this hurts, whatever, so making sure that you put that child, being knowledgeable is very important. Remember, these kids do get infections. They're on a lot of antibiotics. There's no immune system. These children are told any fever 100.5 or higher, they need to call the physician, and they usually will bring them into the ER and get IV antibiotics for it, okay? Also, with platelets down, blood cells down, they're going to have some bleeding at one point. So again, it's that petechial, that's ecchymotic areas, all of that stuff, that they could have it, and it's a sign they need to watch out for and tell their physician. And then, of course, taking care of their mouth and their skin, very important. They could have ulcers in their mouth and stuff. So being meticulous there will do help. Now, cancers of the lymph nodes, lymphoma. One of the ones is Hodgkin's lymphoma. It's usually these ones up in the necks that you can see. And it's basically a painless, enlarged lymph node. But it gets so big, the parents are like, what's going on with that? And the kids doesn't hurt, usually has no symptoms except for that. So the problem with it, if it doesn't get treated and looked at, and they don't do a biopsy, it can metastasize. So, and it could go to any part of the body, and you could see that. What they do is, let's say it's a big neck lymph node. They'll stick a needle in it, do a biopsy, and we'll find those red Sternberg cells. More common in boys than it is in girl. And it's usually that mid-school age area. Because they're big lymph nodes, we can see them. They'll do radiation and chemo, and they have a really good outcome with it. So even though they hear cancer lymph nodes, with treatment, they do well. So what is our treatment for? Well, they're going to be on chemo, the side effects, the nausea, getting antiemetics, pain if they have, making sure they're comfortable, fluids when they need it, treating infections if they have it, looking because of chemo, looking for bleeding. All of these things will be looked at. I think education, your parents and your family can save a child's life. If they know what to expect, what to look for, they'll get in quicker. And that's the key, getting them in quicker. We know malaise after radiation, they get really tired after it. So remember, this child might be irritable, might be a little bit, not, the normal childlike person, but they're miserable, they're irritable, they're not eating, usually they're anorexic. So it's something that as nurses, we need to just sit and listen sometimes. Radiation can cause some of the skin to be like sunburn. And it does hurt. So just remember that. One of the things that I've heard parents say or brothers say, he got radiation. Does he glow in the dark now? Well, no, they don't. And it's something they're not radioactive. And that's important. What if your mother's pregnant, right? The child's mother's pregnant, or grandma, is young enough and she's pregnant. You never know these days, right? So again, support is age appropriate always. The child is going to regulate their own activity. If a kid is tired, they're not going to move. If they can, they will. But, again, keeping fluids in, washing your hands, big thing, okay? And remember that sometimes children that are pubescent tend to have delayed menstruation and whatnot, and they can. And it's often a side effect, sterility, of this treatment. So in Hodgkin's, they might be sterile later on in life. That's one of the side effects. We can cure it, but they may not be able to have a child. So the mother of a 13-year-old boy notices a painless lump on her son's neck. The physician diagnoses early Hodgkin's lymphoma. What anticipatory guidance should be given to the child and the parents regarding the effects of chemo and radiation? What's all the things I just said right there? Nausea, vomiting, malaise, bleeding, right? There's, that radiation can burn, discomfort. There's just so many things to think about here, and, something that they need to be prepared for. So let's go into some gastrointestinal problems now. So GI, mouth to anus, and everywhere in between, right? So what does the GI tract do? It takes stuff from the mouth and it transports it through the intestines down and it passes out the anus. We know that the body starts in the stomach, starts breaking down food, making it into nutrients that the body can use, and then the rest that it doesn't use, you move your bowels, right? And you urinate. Now, one of the things we see in younger kids is something called failure to thrive. And this is when they eat, but their body doesn't absorb it. Could be metabolic, it could be intolerances. So failure to thrive is usually something is, not allowing that food to be broken down and used. Why do you think we do height and weight on every visit for a pediatric child? It's because we are looking to see, are they gaining weight? I mean, as an infant, that first year, about 6 times you're at the doctor's office. in 2 weeks, 2 months, 4 months, 6 months, and usually a year. I mean, right there is 5 visits. And then if they're not sick in between, right? Now, pruritus could be an allergy to foods, but do you know pruritus is also due to liver dysfunction? It's one of the things I learned in the adult world. And yes, it is also in children. They're itchy, 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 do liver functions in their blood test, and we'll find it out. Symptoms in GI? Well, number one is pain. Anywhere from, in the upper chest, I mean, which mimics heartburn, which could be mimicking a heart attack in adults. But in children, it's usually that reflux, could be in the stomach, but that's pain, and when you have GI symptoms and you're cramping, it does hurt. You can have vomiting, diarrhea, constipation, rectal bleeding, and then hematemesis, vomiting blood. One of the things that children can be born with is a esophagus that doesn't connect completely with the stomach. And many times it's connected to the trachea. So what happens? There's fistulas that can occur whenever the infant eats. This is at birth, congenital. This is something that doesn't happen later on. They're born with it. They eat, it goes directly into their lungs, okay? There's all different types, but just know any esophageal atresia, tracheoesophageal fistula, both of these, the stomach is not connected and food goes directly into the lungs. These children will not be fed anything orally until we do something to fix it. Imperforated anus. We're taught in OB, one of the first things we do is to do a rectal temperature, right? Because it's more accurate. You're also checking, is there an anus? Do you know I never saw one of these in my whole career? But I know they're there. I just never saw it. So what do they do with this? Well, what they have to do is an immediate colostomy because the GI tract has to dump out somewhere, right? And then what they'll do is they'll do surgery to connect it in stages later on. So a perforated anus, there's no opening to the outside. Now, pyloric stenosis, this is usually somewhere from 3 weeks to 3 months old. The pyloric sphincter, which empties the stomach into the small intestines, is thickened, narrowed, muscular, and it doesn't let food go down into the intestines. So the child eats, sits there, and then all of a sudden, like those two pictures, just absolutely projectile vomits. You can point the kid at a garbage can 10 feet away and they'll hit it. That's how severe this is. It's not a dribble down the face, it's across the room. What you see with these little children is if you touch their bellies right underneath their rib cage, in the middle, a little bit to the right, you're going to feel like an olive, or I call it a marble, and you can feel it. So these children will need surgery to open it and not, anything totally invasive. But if you know this child has pyloric stenosis, immediately say, okay, don't feed your child anymore until the doctor sees you. And they do an ultrasound for that and they find it and they go to surgery. Now, celiac disease is basically an intolerance to a food source called gluten, wheat, barley, oats, and rye. So no breads, no noodles, no macaroni and cheese, no spaghetti, no cakes, cupcakes. But today we've got a lot of different alternatives. So kids are better today than ever. So what can they eat? Rice. And they have rice noodles and they have rice flour. There's all different things today that they can eat. And what they have is, they don't tolerate any of these the wheat, the barley, the oats, and the rye, and it causes really severe abdominal pain. And when they get to the ER, they're going to probably give them some steroids, NPO. Sometimes they have to empty their stomach with an NG tube, but they're taught, don't eat these things. Now, one of the things about celiac is they don't really absorb fat. So what happens is if you eat a lot of fat, you're also going to see this big belly. You're also going to see them, the buttocks are not going to be as big. They're not getting the nutrition they need. So there's different types of it. There's classic, which is the small intestines, which is what we usually see, the diarrhea, the abdominal pain. The atypical also has anemia, and sometimes you have that peripheral nerve, that radiculopathy of the lower legs. And then the silent one is, you don't know what's going on. And it could be that they're not gaining weight or they see in this belly occurring, what's going on. And they just find it by doing a GI workup. So there is one called a latent, but it's just the wheat sensitivity. Now, Hirschsprung's disease. We find Hirschsprung's disease at birth, usually. What it is the lower descending part of the intestines swells because there's no nerves in it, so there's no peristalsis. So it sits there and gets bigger and bigger and bigger. They call it a megacolon too. And what happens is the end, there's a little, like a little tiny little piece of intestines, very thin. And sometimes some of the contents comes out a little bit, but it looks like a ribbon. It's almost like putting icing in one of those things and squirting it onto a cake. That's the sort of thing that it does look like. So ribbon-like stools would be something you'll see. So what they do again with this one is they're going to do a colostomy, temporary, take out that big piece of intestines because it doesn't have nerves. It's aganglionic. They're taking it out, give the body a rest, and then they reconnect it later on. We see it more in boys and in Down's children. So what would be symptoms that you would see in a child, infant that was born? Well, there's several conditions, but Hirschsprung's is one of them, that there'll be no stool in the first day or two of life. And usually infants come out having stools, right? You usually see it almost immediately. Well, you don't see it, okay? You might see a tiny little ribbon there. And then sometimes these kids are a little bit older and they find it. Could be a smaller portion of the intestines. And again, the kids are constipated and they don't know why. And then they work it up. And the same treatment would be done. They've got to remove that piece of dead bowel with no intestines. So if we don't treat it, the intestines are big. They could get big and they could cause peritonitis, right? It could also cause, nutrition's not getting there, pain, distended abdomen. Sometimes you will see like juice, not stool per se, because only squirts of ribbon will be coming out. We do a rectal biopsy, and the biopsy is going to show no nerves in that intestines, and that's how it's diagnosed. And then again, they'll do a barium enema to follow, and they'll find out really how big is it. And they'll do that surgery, like I said. It's that take that piece out. It's temporary, and then usually they like to before potty training. So 12 months, maybe up to 18 months, they'll do that repair on them. And they usually will be okay. We just have to teach the parents to make sure we keep those bowels moving, okay? So these children, we're going to be watching for several things. Well, as they get older, we're going to make sure that they're stooling and not diarrhea, but normal bowel movements. And of course, because it was a piece of intestines that wasn't working, no nerves, there was no absorption at all, we're going to might see that undernutrition. And we're going to make sure that that distension looking for what it is. So what they do sometimes is called a loop through, one part into the other. And it's what we do with interception. And what it is you have an intestine and one piece sucks up into the other like a telescope. That's what it's called. And these are young kids. These 2, 3 years old is the prime age. I've seen most of them. And their intestines suck up into each other, and these kids go crazy. They're screaming, they're yelling, it hurts. And then it comes back out. One of the symptoms that you look for is what we call current jelly stools. It sort of pushes out a little bit of the mucus from the bowel into the diaper or into the underwear. Could it have a little bit of blood in it? Yes. Not a lot, but a little bit. And then that current jelly looking thing. And the thing is, we don't get that intestines pushed out quick. It could cause this to swell on each other. Stuff can't go down. The intestines could burst and peritonitis. Now, many times I've only seen surgery once on intussusception. I've seen many of them correct themselves by themselves just by increasing the diet. It's going in and out, and we'll do an ultrasound and it corrected itself. So we'll send them home. Now, if it's left in there too long, it'll swell, it won't come out, and we'll need to do surgery. And we cut out that piece of intestines that isn't working. You can feel in their abdomen in the right upper quadrant again, feels like a sausage, like your finger is up there, like you can feel it. It's that intestines in an intestine. Okay. We sometimes, before surgery, we try to do something to pull out that intestine on each other. Sometimes they'll do a barium enema, and in inserting that white, thick, barium enema contrast, it pushes open that bowel. I've seen air used too. They pump up the intestines and it pops it open. And they do it under radiology with a radiologist under x-ray. They're looking at what's going on. And then if that doesn't, it's surgery. Meckel diverticulum, usually in the small intestines, and some sort of sac goes up into with a big blood vessel in it, and it's inside the intestines, and it cracks and rips. So it's a big blood vessel now broken open, and you're going to see it bleeding. Usually we call this painless rectal bleeding. They do surgery, they take it out. These kids do fine. I did that one. Hernias. Now, I used to love touching these little umbilical hernias. If you put your finger in and out, it squeezes in and out. It's called reducible, and it's not a problem. When you push it in and it's painful, that's an incarcerated hernia, and that's an emergency. That intestine had it had twisted around, and that intestine can cause a problem and the death of that tissue. The inguinals are in the groin, umbilicus is in the belly, very common thing. They usually will do surgery to fix it, only for cosmetic. As long as it's soft, it's okay. So whenever we're going to do discharge teaching on GI, we've had an issue with it, whether nutritional, whether surgical. When we send these children home, what are things we need to be concerned about? Well, vomiting, diarrhea, constipation, pain, right? All of the fevers, all of these things, we need to teach our parents so that in case they have a problem, they can bring them right back in. Now, gastroenteritis, this is vomiting and diarrhea of the child. Most common thing that you see. The kid is vomiting, or diarrhea, or both of it. So it could be the stomach and it is the intestines. Colitis is what we call an inflammation of the colon. Enterocolitis is the colon and the small intestines. Everything is irritable. Everything is causing that intestines to have diarrhea coming out. We see it when you start introducing foods to the infant and food intolerance. All of a sudden, you'll see them vomit diarrhea. You introduce, let's say, green beans, they didn't like it. Well, the intolerance is going to cause vomiting diarrhea. That's that food intolerance. If you overfeed your child, they will vomit and have diarrhea. The body can't handle overabundance of food. What if they made the formula and they left it out too long, or not the right material, or they used tap water? You know, these things can cause diarrhea and vomiting. And then ingestion of high amounts of sorbitol, which is a preservative. So usually it's not that, it's the other. But what is our big concern about vomiting and diarrhea? You're losing fluid. You're losing electrolytes. So we need to replace the fluids and we need to replace the electrolytes. Usually, unless they're vomiting a lot, we will give Pedialyte, Gatorade, Powerade, something to replace the fluid and to replace, the electrolytes. Vomiting, again, can cause that dehydration and electrolyte. We know that acid is thrown up. So, what acid base would you see? If you're vomiting, throwing out acid, what is left? Alkaline. So, you're in metabolic alkalosis. Okay. So, you're left with alkalosis. And we don't want to leave it there because the body doesn't like to be out of pH normality. We don't want 7.6 pH. We want that 7.4, that 7.45. That's where we want it, okay? What causes vomiting? Well, I've already mentioned a few, but it's the feeding, overfeeding, not burping, that can cause it, but head injury, any intracranial, always in kids. You can have head injury in children and they're going to vomit. Adults don't do that. And remember, with vomiting, all of these children are at risk for aspiration pneumonia. That's why we sit up children, babies, after we feed them. Reflux, that's vomiting, spit up on your young children. And again, big problem is aspiration pneumonia with these children. When you have reflux, many times you have a child who has neuromuscular delay like Down syndrome, any of those that they don't have more control of themselves. And again, we try to decrease it as much as possible. Diarrhea can be due to many things. Could be due to, again, the food, could be due to a virus, could be due to E. coli, many things, right? So, chronic diarrhea, they say, is more than 2 weeks. And again, if you're having diarrhea, you're losing nutrition. And with nutrition, again, you're going to create more problems with these children. So we don't want it to become that chronic. We want to catch it before it. And infectious, we want to treat the cause. I mean, viral is systemic, just what happens. Okay, ibuprofen, acetaminophen, fluids. Bacterial, they'll be getting antibiotics, or parasitic, they'll be given some medications to treat the cause of the diarrhea. Now, constipation is a common thing with children, especially those toddlers going through potty training, right? They don't know when to go, when to hold, or they're holding it, or they're shy, don't want to do it in front of people, or what, it could be that cultural, that social, right? The family. Now, one of the things that we see with constipation is periods of what we call encopresis. It's constipation, but you get a little bit of fluid soiling. So inside is a big hard stool, but a little bit of the soft stuff comes out. Encopresis, okay? And remember, there's something usually going on with these children. It could be diet, could be stress, all of those things. And we do not routinely give laxative or enemas, okay? An enema would be a quick release of what's there, but we would tell them they need to increase fiber in the diet. I mean, the only type laxative might be something like Miralax or like a Metamucil on adults, but in children it's called a Miralax. Now, fluid balance we cover in GI because you vomit, you diarrhea, you have fevers, you're losing a lot of fluid, right? So we know that the skin loses a lot through fever. So again, we need to replace fluid if a child has a fever. Small, frequent sips of it will really help. We know that if a heart rate's up, we know if we're breathing a lot. Tachypnic, we have fluid in our mouth. We are, again, expelling fluid in our breathing, okay? So we've got to be remembering fevers and tachypnea and, knowing that fluid is going. And then put vomiting and diarrhea on it. Now you're losing a lot. So dehydration loses a lot of fluid and it loses electrolytes. The big one we worry on is potassium and also sodium. All right. How do we figure out if they're dehydrated? Well, number one, we're going to do a blood work on these children. We'll do electrolytes and we'll be looking at their sodium level and we'll be looking at the potassium in there. Now, hypertonic, isotonic is what the body likes. That's the 0.9 normal saline. That's just what our fluid should be. Sometimes we vomit a lot of electrolytes. Now, that's going to be a hypotonic. And then, because it's less than what you want, the normal of isotonic. Hypertonic is when you have too many particles in your body. We can give hypertonic solutions to replace sodium, 3% saline. There's things that we can do to replace things quickly. Now, dehydration, of course, is when you have not enough fluids. Overhydration is when you have more intake than you have output. There's many reasons for it. We'll go over some with GU, but what we know is that in overhydration, you'll see some sort of swelling, edema somewhere. It could be in the eyes, it could be in the feet, it could be anywhere that you see the fluids going on. It could fill up the lungs, right? Cause congestive heart failure. So there's a lot of things. One of the things that really affects over fluid is low protein. So we will be monitoring that protein level to make sure that's not what causing the fluids to go intracellular and make extracellular, making all of this swelling. And another word for you is anasarca. That means you see swelling everywhere. Now, nutritional deficiencies, failure to thrive. I've seen 8-month-old babies that were still 8 pounds. They have done everything looking. Why? There's something going on with the child. Well, failure to gain is, and sometimes they're losing weight, and it's because they're not getting nutrition. Or, well, what if they're a congenital heart and their heart is working extra hard in order to get, the oxygen around, it's burning calories like crazy, right? They're not gaining weight. That could be something. But usually, when you see failure to thrive, you're talking older children. It's usually some malabsorption. It could be something to do with a metabolic, could be lactose intolerance. Many different things can cause nutritional deficiencies and failure to thrive. Also, it could be neglect. I actually had one case of a child who, that little boy down there on the bottom, I had a 5-year-old boy came into the ER looking like that, where the father had stopped feeding this child. And he came in with not an ounce, not even a gram of fat on that child. So neglect can happen. Okay. I mean, we would think it doesn't, but it does. I've seen it. Now, if you're not getting nutrition, what's happening? What do I've said from the beginning? Nutrition, nutrition, nutrition. If you're not eating, you're not getting calories, nutrition to the body. The body is not going to grow, and you're going to have cognitive delays, developmental delays. They're not going to be lifting their head, turning over, getting up, walking, fine motor skills, none of it. They're just not, because they don't have the energy, because they don't have nutrition for their bodies to work. Okay. I mean, there is, when, go through that depression of the mother at first, where they can't take care of their children. It is real, and it does happen. I had a niece who went through, a whole bunch of stuff with her child in the beginning. And she's lucky. She had a great husband and a great grandparents that assisted her, with the child. I mean, we know that environmental, we know that social stuff. If we see it as nurses, we need to report it so we can take care of it, okay? I mean, sometimes physicians know before the baby's born there's going to be a problem, but usually that's after that. Now, an infant's admitted to the hospital for dehydration related to gastroenteritis and vomiting. The nurse observed the infant's mother immediately placed the child flat in the crib after a feeding. What should the nurse do? They just fed, put him flat. That goes against everything, doesn't it?
Put the baby in kind of like in an upright.
They should be sitting up for 30 minutes after the feed. This child's going to aspirate. This child's going to vomit, and it's going to be a lot more problems. So, and also, why is she getting rid of that infant so quickly? Why isn't she holding it and comforting it? There might be a disconnect. That's another thing. Appendicitis. So appendicitis is that little thing that's in between the small intestines and the large intestines at the cecum, it's called. And it gets swollen and it creates a lot of pain, and it pronounces with right lower quadrant pain at the McBurney point, right? Appendix that you're still in pain, it's actually good because we know it hasn't burst yet. Once the pain disappears, they're going to go into peritonitis and septicemia. So, right lower quadrant pain, we need to get them to the OR as quick as we possibly can. Thrush could be caused by many things. If you're Spanish, it's the ongle, right? It's that white thing that you try to scrape it off and you can't get it off. It is a fungus. It's painful, okay? What we do is we take the medicine and we take a swab, and it's called nystatin, and we swab it on their tongue, their mouth, and their gums, and it'll go away. Again, teaching the parents, if they're breastfeeding, to make sure that they clean their breasts, their nipples before they eat. And of course, bottles, making sure that they're washing them properly. Kids love to go and sit in dirt and then puts their fingers in their mouth, don't they? And what they say is in this dirt could be pinworms. Another name for these worms to go into the body, usually the kids with longer nails, goes into the mouth, and then it goes into the intestines. And then you're going to have at night, their anus is going to be itchy. It's going to be, they're going to be scratching it. Okay. It's called enterobiasis. What we do is we've got to find out, why are they itching? Is it just a dirty, rectum they didn't clean well? Or is it, these pinworms? Well, what they do is let the kid go to sleep. And then with a flashlight, go in and look at their anus and take a scotch tape and put it on there, and then take it and then look at it. And usually you see tiny little white little worms. That's what they do to find and get these things, because they don't come out during the day. It's only when it's dark and at night and when the kid's not moving. And then there's medications they take and it will go away. Roundworms are bigger worms. These are more in the South, more with immigrants, okay? It has to do with unsanitary conditions. It also has to do in those areas, again, it's in the soil. The kids are in the soil playing, making dirt piles, playing with their trucks and whatever, and then their nails. Again, keeping short nails is important on these children. And then these worms grow and grow and grow, okay? It goes through the intestines into the livers, can go into the lungs. I mean, we might see this cough. It might be worms, okay? It can be treated, and we do treat it. Now, every parent should have this number programmed into their phones, poison control. Whenever you see a kid eat something or drink something or put something in their mouth that you're not sure about, I've seen rat poison, I've seen grandma's heart medicine, I've seen a lot of vitamins, those really good tasting things. The kids like to eat them. Tylenol's the worst that they could get into. But what is our goal with poisoning? Well, number one, what do we need to do to take care of this kid? Parents need to call poison control and get to help. All right. We never promote vomiting with children because they can aspirate, right? So we would hope you take the poison away, whatever they're eating, prevent that further absorption. It could be in the hospital, charcoal that they have to drink. And in the ER, the triage nurse also will call poison control, and they will tell us the most up-to-date treatment. And that's how we're going to treat it. And they call back to see how the children are. It works really great. How would you know what stuff was in case they vomited? Well, these are the things that we would see. The odors, whether it's sweet, like a bitter almond, pear, garlic, we're going to know what it is by the smell. And even if we don't know what content, we call poison control and say, oh, it smells really sweet. Oh, it smells like a garlic. They can tell you again what the treatment for this is. Now, in older areas with older homes, they used to paint with lead paint. Now, you're going to say, well, it's gone. Nobody's used it for years. What do children, especially your young, early toddler kids do? If there's windowsills, they like to go up, look out the window, and everything in the mouth, right? They chew on windowsills. And what they're doing is they're getting pieces of paint in their mouth and lead in their mouth. And it is called pica, P-I-C-A, when they're eating foods that they shouldn't, whether they could have or not. And remember, these young kids are teething, so it feels really good to them, right? So we have to be careful. Now, it creates iron to go up in the body, and if there's too much lead, iron in the body, it causes mental retardation. And they're going to have to get that removed somehow, whether medications, dialysis, whatever the physician thinks. Now, foreign bodies. You know, the most common of foreign bodies I've ever seen is a quarter. Not a dime, not a penny, a quarter. I'm like, why a quarter? Well, 3 weeks ago, my 9-year-old grandson swallowed a quarter and it got stuck. And he actually had to go to the hospital, to the OR, and have it removed by endoscopy. My 9-year-old grandson, just recently. But again, what do kids do? Everything in their mouth. Now, my daughter-in-law called me up and said, so should I be concerned? I says, well, it will pass, but if he starts having abdominal pain, go get help. And what happened, it couldn't go from the esophagus and it couldn't pass into the stomach. And he was complaining of pain. He could drink, he could eat, and he did, but then he had the pain. And that's why he had to get in. And again, never use laxatives. If he got it through, I told her you need to be checking his stools, making sure that it does come out. Okay. So a father brings his 2-year-old child in the ER. He's holding an empty bottle of aspirin and tells the nurse that we're 10 325 milligram tablets. How should the nurse respond? Well, did you call poison control? When did he take them? Right? Has he vomited? Has he eaten? All of these things are so important. You need as much information as possible. What does aspirin do? It's an anticoagulant. It makes the blood thin and it is dangerous. So it is something that needs to be looked at. How do we reverse that? Well, does vitamin K reverse an aspirin? Maybe. But this is something that, again, poison control will be saying, draw these labs, give this treatment. So a lot of information today, a lot about all different stuff. So who wants to do a cahoots and who wants to win today? Nobody? Okay, I saw Keisha.
Yes, I want to win.
Yes.
Okay, thank you. Here we go. I think there's 30 questions on this one. So there we go. Somebody's yawning. It's a
Sorry.
Friday. It's okay. It's Friday. I get it.
We have an exam after this class,
Ooh.
community, yeah. Well, some of us.
Well, I wish you the best. So Kimberly, you gonna win today? We have a big daddy today. Okay. Yeah. Okay, here we go. Let's just get her done. I know some of you want to sit there and just listen, and I know you're with your exam coming up. I get it. Which finding in a newborn is suggestive of a tracheoesophageal fistula? So the trach in the esophagus has a connection. That means everything that swallows goes into the lungs. What are you going to see? If you swallow, it goes into the lungs, they'll be choking. That's one of the things. They're like, if they're feeding and every swallow they're choking and gagging, this is something that we would stop the feed and tell the doctor, and they need to find out why. A child's been vomiting for the past 2 days. What acid, base, and balance would the nurse expect? Well, what's in the stomach? The stomach is acid, right? So you're vomiting acid. What are you left with? And also remember, anytime with vomiting, diarrhea, you always worry about electrolytes, specifically your potassium. So when you vomit, you're losing acid, you're left with alkalosis. Now, when you have diarrhea, all of those the digestive enzymes are alkaline, so you're left with acid. So your metabolic acidosis. Those are the difference between your vomiting and your diarrhea and your acid balance. Hereditary blood disorder that the body does not produce enough adult hemoglobin. So it's hereditary. You don't get enough hemoglobin or blood cells. And this is your thalassemia. It's the adult hemoglobin. It's immature. It bursts right away. It doesn't work. This is the condition, Cooley's anemia, that needs blood transfusions to live. Why are rapid respirations a possible cause for dehydration? I mentioned this about, fluid, right? What happens? Tachypnea. Why does it cause you a possibility to lose fluid, cause dehydration? Well, you got fluid in your mouth. Breathe, open your mouth and breathe in and out. You're just getting rid of all the fluids. And then you have to move your mouth to get it wet again, right? It causes that evaporation. What would the nurse expect the parents to report of an infant with pyloric stenosis? Remember, that's that little olive or marble in the right upper quadrant. The pyloric sphincter is thickened and it doesn't allow anything to go from the stomach into the intestines. This is projectile vomiting. A parent who comes in with an infant 3 weeks to 3 months that's vomiting, my first question, are they dribbling or can I aim it across the room? And then you'll know the difference. A multi-select. How would you treat chronic constipation in children? And we know we don't just routinely give laxative and enemas to children. It's very dangerous because they'll be like that their entire life, and then it's not going to work. So, high iron food causes constipation. Cooked food burns out the fiber. Raw vegetables has the fiber, and then you give fluids, which makes it softer. It's those two. A child's been scratching the anal area and complaining of itching. What does the nurse suspect? And again, to prevent these things, take those children and have the short nails, especially if they like to go outside and play in the dirt. I had 6 brothers. We were always in the dirt somewhere doing something. And it is pinworms. What instructions will the nurse give to parents about preventing the spread and reinfection of pinworms? It's all about the nails, believe it or not. It's not like when you get, lice in your hair that you've got to wash everything in hot water and whatnot. It's all about those nails and making sure we prevent them. Which food would the nurse recommend to include in the diet of a child who constipation frequently? Remember, constipation, it's raw vegetables, right? It's increased water or fluids. What else? Again, you're looking for fiber here. And it's the whole grain cereal. Very good. Yogurt really has nothing to do with constipation. What condition is characterized by pain in the right lower quadrant at the McBurney's point? What is that? And this is an appendicitis, right lower quadrant. These children walk into the ER bent over, holding their right groin and limping on their right leg. And you're like, that's an appendix. You can tell. What description of a child's stool characteristic leads the nurse to suspect intussusception? It's when the bowel go intestines telescope into each other. Remember I said you have to look at their underwear or their diaper, right? What do we look for? And it's called currant jelly. It's like clear, a little bit of blood. It's very distinctive. It's like the inside, lining type of comes off. Currant jelly. What does a nurse expect the appearance of the stools of a child with celiac disease to be? Remember, this has to do with nutritional, that they don't digest foods, gluten foods. So the foods aren't being digested in the intestines. What do you think would happen? Big abdomens, right? And it's what we call bulky and frothy. That foul smelling is your cystic fibrosis. Bulky, frothy is going to be your celiac. A 7-month-old infant is admitted with a diagnosis of acute gastroenteritis. What will the nurse's priority goal be? Gastroenteritis. Well, what is that? That means the stomach to the intestines is inflamed, probably vomiting, diarrhea. One, the other, or both. What's our big concern? Immediately and initially, it's that fluid and electrolyte imbalance. If it continues, it would be nutritional. A surgery for pyloric stenosis, after surgery, the infant's crying and hungry. What's the appropriate nursing action? They go in, they dilate that valve, they open it up, and food can pass. These are infants. Infants are really apt to get hypoglycemia extremely quickly. What do you think would be appropriate? We're going to give either glucose water because it's got sugar, right? Or maybe Pedialyte. We'll start with that, see how they tolerate it, and then we'll work up into breast milk or formula. A multi. A child's brought into the ER with suspected appendicitis. What are the signs and symptoms? And it's rebound tenderness and it's right lower quadrant. And then when you try to lift the legs up when they're on their back, it causes a lot of pain. Which statement by a mother may indicate a cause for her 9-month-old's iron deficiency anemia? So what do we know about iron deficiency anemia? It's due to a lack of iron in the diet, right? So lack of iron in the diet would bring you to formula is expensive and we switch to regular milk. That's why we keep them on formula or breast milk for the first year of life. What regulates how many RBCs are produced? It could be in the kidneys or it's something that we can give in a sub-Q injection. And it's erythropoietin. When you're in kidney failure, chronic kidney failure, you're not producing enough erythropoietin and your red blood cells go down. That's why there's low hemoglobin hematocrit. So erythropoietin, it's all about red blood cells. And we can also give sub-Q injections, and we would give it to that chronic kidney failure, or even some children with leukemia that need more cells. What information should the nurse include in a teaching plan about home care for a child with hemophilia A? Well, what is hemophilia A? What's hemophilia? So hemophilia is bleeding. We know children fall down. They hit their knee is swollen. How do you decrease that swelling? Well, you're going to give a factor eventually, but initially you're going to rest, ice, elevate, and contain it with an ACE bandage. And ice constricts it, right? And that pressure of an ACE bandage will keep it up or something wrapped in there tight. And then they'll get the factor because we don't want that bleeding to continue. We want to save that joint from destruction from that blood. What will the nurse teach the parents of a child with a low platelet count to avoid? What do platelets do for the body? And we don't want them on anything with aspirin, nothing that's going to cause more bleeding and prolonging bleeding times. Very good. A children with leukemia has widespread purpura and a platelet count of 19,000. What is your priority with this patient? What does a platelet count of 19,000 mean? So we know platelet counts that are low, there's chances for bleeding. So we want to make sure that it's not in the brain. That's the number one priority that they're awake and alert and we're not bleeding into the brain. Okay. And then, of course, it's going to be bleeding precautions. They might get a platelet transfusion, but initially, you're going to see what's the status of that child first. Which statement indicates an understanding of health maintenance of a child with sickle cell disease? What does sickle cell? When do we have a crisis? When do we see those cells clump up? We see it when they're dehydrated, vessels are small, or when they're cold. The big thing is to keep these children hydrated. If they're out with any sort of sports, making sure that they are drinking, drinking, drinking. They even say going up in an airplane, they should overhydrate because that pressure cabin squeezes those vessels down. Most common cause of anemia in children. And it's nutritional, iron deficient anemia. Remember, we need to give them green leafy vegetables, some liver, if I'm going to say like liver. I always love liver, but meats, and also getting maybe iron, giving it orally. Make sure we give it with orange juice, never milk, or sometimes there's IM injections that we give for that too. What is a complication of repeated blood transfusion for a child with thalassemia major? Remember, thalassemia major is that child from the Mediterranean Sea, and their cells, they're rectangle, they're misshaped, and they burst, and it's just constantly low, low, low hemoglobin and hematocrit, right? So then they're constantly getting blood transfusions to replace it. And it's hemosteriodosis. I mean, things happen to the bloods. I mean, there's more things than this. It can cause little weird antibodies to go in the blood. There's, long-term effects. It's hard to keep these children into adulthood getting blood transfusions because of all the different sort of reactions and extra stuff in it. So hereditary condition where the blood does not clot normally. What's it called? Does not clot is hemophilia. Thalassemia, the cells burst, they don't produce proper cells, and it's blood transfusions. Sickle cell is sickle shaped, and this is because the vessels get too small. You need to keep hydrated. And ITP is all about platelets. A recent blood count for a child who received chemotherapy shows neutropenia. What is a priority nursing diagnosis? What's neutropenia? Neutropenia is not enough white blood cells. No white blood cells. You have no defense against infection, so it's a risk for infection. Our number one thing is hand washing. What type of cells carry oxygen and carbon dioxide in the blood? And they're the erythrocytes, red blood cells. What can occur what can occur iron deficiency anemia go untreated? So if you're iron deficient, you don't have enough iron in your body, what can happen? You're anemic, you have no red blood cells are not carrying oxygen around. The heart says, let me beat harder, and it is. It is heart failure. That's one of the biggest concerns with any anemia. A multi. What skin assessments would alert the nurse to bleeding for a child with a low platelet count? That's your ITP, thrombocytopenia purpura. So it's all sorts of things that look like bleeding. You'll see the ecchymosis, petechiae, purpura. The lymphadenopathy has nothing to do with the lymph nodes. It's all about blood and bleeding. You might see this anywhere, inside the mouth. You can see sometimes the petechiae, that little blistery purple things. What's the name of the malabsorption problem that results in gluten intolerance? Gluten, what is that? Wheat, rye, barley, and oats. Can't have it in your diet. Body doesn't like it. Body doesn't absorb nutrients right in this one. This is your foamy stools, right? And it's celiac disease. But they can have rice. And there's a lot of things with rice today that they do use. Last question. Hereditary blood condition where the RBCs are crescent shaped. And that is your sickle cell anemia. Yes, it is. All right, let's see how we did. Number 3, Kimberly. Good job, Kimberly. Number 2, Chrissy. Good job, Chrissy. Number 1, Eve. Look at you. Number 4, a DW and a Yaya. Okay, guys. If you want to stay, I will go over that exam, that quiz that we did, to let you know some of the answers. Does
Professor,
anybody have any
I was
questions?
wondering if I could go in a break room with you.
Well, it's the end of the class, so everybody's going to leave anyway, but we can talk. We can talk.
Okay, thank you.
You're welcome. Anybody have anything else?
No,